Hi, everyone. It's such an honor to be here. And I'm really excited to talk with you about glaucoma medications. In the last 5 to 10 years or so, there have been a lot of new medications on the market, and I'm going to be going through those. So this is the San Francisco VA. It's just up the hill from us. That's where I spend most of my time. It's beautiful in this photo. Oftentimes, there's a lot more fog if you spent very much time in San Francisco. And so I'll give just a brief overview on glaucoma. And I assume most people know what glaucoma is here. You're such advocates already being in this room. But I often encounter patients I see in clinic who've been diagnosed with glaucoma for years. And when I ask them, do you know what this disease is? The answer is often no. And of course, there's a lot we don't know about glaucoma. That's why the Glaucoma Research Foundation is so important. But I'll give you my little spiel. So glaucoma is an eye disease, often, but not always, associated with high eye pressure that damages the optic nerve. And you can think of the optic nerve as this cable that connects the eye to the brain. And if that cable is damaged, what we see in the world isn't being transmitted back to the brain, and vision loss can occur. Inside your eye, a clear fluid called aqueous humor is constantly being produced and drained. And when drainage is too slow or production is too high, then pressure can build up inside the eye and cause damage to this optic nerve. And so I use the analogy of a sink with a faucet, producing water, and then there's a drain. In actuality, there's actually 2 drains in the sink. And if that equation gets a little bit out of whack and eye pressure goes up, that's where we get damage to the optic nerve. We call this eye pressure intraocular pressure, and you've probably heard your eye doctors refer to this as IOP, so it's just the pressure in the eye. The tricky thing is that the amount of pressure that will damage an optic nerve is different for everyone. So I see patients all the time that have quite high eye pressure, but they don't have glaucoma, or they have very low eye pressure, but they still have glaucoma. And so this is different and not something that, you can't talk to your friend next to you to see what eye pressure might be healthy for them and compare it to yourself, because it's going to be different for everyone. And yes, like I said, some people will have glaucoma even with normal eye pressure. And so when we think about the treatments for glaucoma, the spoiler alert here is that lowering eye pressure is still the main goal of all current glaucoma therapies, even if the eye pressure is already normal to start with. So it's kind of still the same toolbox, but we have a lot more tools in the toolkit. There's a lot more ways that we can lower eye pressure. And so I have this children's toolkit example up here because I have young kids. But it's still, if those tools go on the floor, they still hurt when you step on them. And so why do we treat glaucoma? It is the leading cause of irreversible blindness worldwide. If untreated, it can cause gradual loss of the peripheral vision, your side vision, and in some cases lead to blindness. There are many different types. The most common type is open-angle glaucoma, and as many of you know, for most of these types of glaucoma, there are no symptoms early on. And because these changes often happen gradually, your brain adapts, and people won't realize that they're slowly kind of looking through more of a pinhole, like tunnel type of vision, until the disease is quite advanced. The overview of glaucoma medication classes really boils down to 2 main buckets of eye drops that we prescribe. And they work on either the faucet, the part of the eye that's producing the fluid, or on the drain, the ability for the eye to drain the fluid. So the types of drops that turn down the faucet or reduce fluid production are beta blockers, carbonic anhydrase inhibitors, and alpha-agonists, and I'm going to talk about each one of these and their cap colors in a minute. There's also eye drops that open the drain or increase the amount of fluid that can flow out of the eye, and these are the prostaglandin analogs and the rho kinase inhibitors. There's a representative photo of a drain. And some of the newer medications and combination drops can actually work on both pathways, which is really exciting. And so before I start talking about all these drops, I just want to review how to get an eye drop in your eye, because it's not as easy as it sounds. And this will just be brief, but first is before you start to wash your hands thoroughly with soap and water, you want to tilt your head back And so sitting in a chair, tilting your head back, or lying down on a couch, or having someone assist you is very helpful. And I actually recommend pulling down on your lower lid so that you form a little pocket between your eye and your lower lid. And I know you're all thinking, she did not wash her hands before touching her eye, but there's no sync up here. Pull down on your lower lid to create a pocket, and then place the eye drop in that pocket. And you can balance, aiming can be quite difficult, and so stabilizing your hand on your forehead or your nose can be very helpful. One drop is enough. Putting multiple drops in the eye, although that's not going to hurt the eye, it's not going to make the eye drop work better. Then you want to let go of your eyelid and gently close your eye. There are commercial products online if you have trouble aiming to either stabilize your hand or stabilize the eye drop on your eye. And a lot of patients will have a hard time knowing if the drop went in. Like, it's kind of hard to feel an eye drop sometimes. And for the right drop, I'll actually recommend putting it in the refrigerator before using it, because it's easier to feel a cold drop hitting your eye as opposed to a room temperature drop. Okay, so I'm going to start talking about the most common starting drop treatment, and these are the prostaglandin analogs. So, I think probably most people in this room have been exposed to a prostaglandin analog at some point. All of these end in prost, so latanoprost, travoprost, bimatoprost. I have the name brand there next to them, tafluprost, and this is my favorite glaucoma eye drop, and that's because it works the best of the eye drops, and it just needs to be dosed once daily. The eye pressure lowering from prostaglandin analogs lasts more than 24 hours, and they're generally well tolerated with no body-wide side effects. So there's going to be eye kind of specific side effects, but it's not getting into your body and causing other side effects. There's just some photos showing the different eye drops. They're often in a small bottle with like a teal cap color. And these work by increasing the natural drainage of fluid out of the eye, the uveoscleral pathway to be specific, but it's working on the drain essentially. And so I mentioned there's no body-wide side effects, but there are common local side effects. And one of the big ones is that they can cause eye redness. And so in this photo, the top is the patient before using a prostaglandin analog, and then in the bottom, you can appreciate the right eye is a little bit red from using the prostaglandin analog. It's not hurting the eye, it's just making it a little bit red. And for that reason, we recommend using it if you can in the evening before bed, because by the time you wake up in the morning, a lot of that redness will have worn off. They can also cause gradual darkening of the iris. Mostly, that's the colored part of the eye. Mostly in patients that have hazel and green eyes, over time it can actually make that eye color a little darker. It's not something that's going to happen right away. We're talking about months of use. And I've thought about using this for myself. It can make your eyelashes longer and thicker, and prostaglandin analogs are used cosmetically for people's eyelashes. It also can cause darkening of the skin around the eye, and so if drop is getting kind of around the eye, I recommend wiping it away, and it can cause loss of fat around the eye as well. And so you might be thinking, this is my favorite eye drop. This is kind of like the first go-to prescription eye drop that we prescribe for patients with glaucoma. Is there another first-line therapy that's not eye drops? And the answer is yes. There's a laser procedure called selective laser trabeculoplasty, or it's really like a light therapy. And I'm not going to touch any more on this because next lecture by Dr. Pickering and Iwa will be on these light-based treatments. But essentially, you can think of it as light that's applied to the drain in the eye to help your eye more naturally lower the eye pressure. And so I give the analogy of, it's kind of like sending your patient to the spa where there's light and laser to more naturally help you lower eye pressure. I think Dr. Iwa will have a better analogy shortly. The next very common kind of camp of eye drops are the beta blocker eye drops. These are the longest used and most well-studied glaucoma medications that we have. They often come in a yellow or blue cap bottle. And these work by reducing the amount of fluid your eye produces. So it's working on the faucet. They're usually dosed once or twice a day, and they last about 24 hours. They are best used in the morning time. So if you're prescribed this drop for once a day dosing, they're most effective if used in the morning. If it's prescribed as twice a day, I recommend morning and evening time, but to ideally try and avoid using it right before bed. And the reason for that is because it may lower your blood pressure a little bit while sleeping, which isn't necessarily a positive thing for your optic nerve. Yeah, the eye pressure lowering lasts up to 24 hours. There are some body-wide side effects from timolol eye drops. And so timolol can slow heart rates and worsen asthma and COPD, chronic obstructive pulmonary disease. And so I really try to avoid prescribing this eye drop in patients that have severe asthma, they have severe COPD, because it theoretically could make this worse. I do have a little bit of a trick for trying to decrease the amount of eye drop that gets absorbed into your body, and this is called punctal occlusion. And so after placing the eye drop in the eye, after you've washed your hands and you've placed the eye drop in the eye, if you gently press on the inner corner of your eye, so it's not like plugging your nose, it's like, I actually have a photo of an eye model, very expensive rate eye model photo. So very, it's like the inner corner of the eye. In this photo, I actually ideally would be closing my eyes, but if you press in that spot, that's where the eye drops often kind of drain into the nose and can get absorbed systemically. And so if you press on that spot after the eye drop for 1 to 2 minutes, it can decrease the amount of body-wide side effects that you might experience. And this is called punctal occlusion. So so I've talked about the prostaglandin, which is really a first-line therapy, then the timolol or beta blocker eye drops, which are first or kind of second-line therapy. And then if more eye drops are needed, one other option that we have are alpha-agonist eye drops. These come in a purple cap typically. The most common generic name you'll hear is brimonidine, or the brand name Alpha-Gan-P. And these work by reducing the amount of fluid the eye produces and may also help with drainage. The kind of downside of brimonidine is that these drops last about 8 hours. And so they need to be dosed 2 to 3 times a day. And that's not like, one drop and then another and then another. It needs to be spread out over the course of the day so the eye pressure isn't going up and down too many times. Oh yeah, there's a smaller photo. It's mostly working on the fluid production, but there is a smaller component of helping your eye drain the fluid. The main issue that I have with brimonidine or the alpha-agonist eye drops is that sometimes patients will develop an allergic reaction to them. And if you think about medicines and allergies, often the allergy is like right after you take the medicine, like you're going to be allergic to something. But with brimonidine, this allergy can come about months, and there's even case reports of years after tolerating the eye drop for a really long period of time. So just something to be aware of, that this drop is associated with. It can be associated with allergies like itching, redness, swelling of the eye, and it's one of the more common reasons why we end up taking patients off of the brimonidine eye drop. It also can cause dry mouth, and there are some reports of patients having more drowsiness or fatigue after taking the brimonidine eye drop. And so the punctal occlusion, it's not going to help with the allergy component, but it can certainly help decrease the amount of dry mouth or drowsiness that you might feel after using the eye drop. Excellent, okay. The next kind of type of eye drop that you might be familiar with, they're the carbonic anhydrase inhibitors, the CAIs. These come typically in an orange cap, and these eye drops slow down fluid production, and by that mechanism, lower the eye pressure in the eye. The two main ones that we have are dorzolamide and brinzolamide. And similar to brimonidine, they last about 8 hours, and so they're going to be dosed 2 to 3 times a day. And this is also why I prefer the prostaglandin analogs to these drops that need to be dosed so many times, because it's just more convenient. So they can be used alone, but more frequently as an add-on to other glaucoma drops. So you're already on a prostaglandin, the eye pressure needs to be lower, this would be something that could be prescribed. The main side effect that patients always tell me is that they burn, they sting. Sometimes I try and warn patients and I'll say it's going to tingle, and then they come back and say, no, it just stings. I don't know why, I need to be more upfront about it. They do sting. And then there's often a bitter or metallic taste when it gets kind of in the back of the throat. And so the punctal occlusion can help if the bitter or metallic taste is bothersome. It's also available in combination drops, which I'll be discussing in a little bit. So we now have some newer medications. One of them is called Notarsidil, and the brand name for this is Ropressa. These are ROCK inhibitors, and it's really exciting because it works in 3 ways. It opens the main drain of the eye. It actually also lowers pressure in the drainage veins, and they may also reduce fluid production. So it's kind of working on 3 different pathways. It's also very convenient because it's dosed just once, typically in the evening. It's not as effective as the prostaglandins, however, and the most frequent side effect reported, which can be significant, is that it makes the eye red, and you can get like a little bit of bleeding on the white part of the eye from these eye drops. So it's not harmful to the eye in any way, but it can be cosmetically not ideal. I will say that most of the redness is actually going to be worse in the first month after starting the eye drop, and then it can actually get better. And so I try and encourage patients, especially if it's helping lower eye pressure, to try it out for at least a month before deciding that the redness is too much and wanting to go off of the eye drop. There's an even newer medication called latanoprostene Bunod, the brand name Vyzulta. And this is a drop that has a great kind of dual mechanism. So it has the prostaglandin, that, my favorite eye drop component, plus something called nitric oxide. So it's opening up the uveal scleral drain, like your typical latanoprost, and then also opening up the second drain, the trabecular meshwork. It's a second drainage pathway. And so my initial analogy of the sink, I really should have included the photo of 2 sinks with 2, or I feel like older kitchens, you have 2 sinks with 2 drains, but they're still connected, so that's perhaps a better analogy. It does work, this nitric oxide, this extra component, so it does lower eye pressure a little bit better than latanoprost alone. It's still dosed once in the evening and has the same side effects of a little bit of the redness, the eyelash growth as your typical prostaglandin analog. The reason I don't see it being used as first-line therapy is just because of cost. So it's still more expensive than like a generic latanoprost. And so at the VA, we're not able to prescribe this right off the bat. It still has like that teal cap color. And so when 1 drop isn't enough, your eye doctor may prescribe a second medication. And what is convenient is sometimes these medications can be combined. So combination drops will put 2 medicines together and reduce the number of bottles that you have to carry around. So we can combine brinzolamide and brimonidine, that's can be referred to as Simbrinza, dorzolamide and timolol, brimonidine and timolol. There's also compounding pharmacies out there that can even combine like up to 3 or even 4 eye drops into 1 bottle. The shelf life isn't going to be as long, so after a month the drop might need to be thrown away, but that can be very convenient, especially if you're struggling with putting in multiple drops a day or keeping track of all the bottles. We are in a very exciting time now where there are drop-free glaucoma implants. The first one that has been approved by the FDA is a bimatoprost. So this is a prostaglandin implant that's actually placed inside the eye. So it's basically injected into the front part of the eye, and this implant slowly releases prostaglandin over months to lower the eye pressure without having to use the eye drop. And so that's, you can think about the benefits of this if it's hard to take the drop, if the eye drop is irritating the front surface of the eye, this can help with that. You're like, is there a picture of a dime? And it's because it's the size of the eye, and Liberty is the size of this little implant. Yeah, and so it slowly releases prostaglandin over 4 to 6 months. There's some newer data showing it can last at least up to 18 months, work for at least 18 months. The downside is that it's only approved to be injected into the eye once. So after that 18-month period, when the eye pressure starts going back up, it's not often injected again. Sometimes that's being done off-label, but it's not part of the approval right now. And so there's decreased concern about drop adherence and side effects. The medicine is being released slowly, and so we know, the optic nerve doesn't like it when the eye pressure goes up and down, up and down. And so since this is just slowly kind of continuously being released, there's less of that eye pressure spike. And then, yeah, it's approved for just a single administration right now. There's another type of glaucoma implant. So Durysta, which is the bimatoprost implant, this biodegrades over time. So it dissolves in your eye, and at a certain point, it's not going to be there anymore. But the travoprost intracameral implant, the iDose, this is actually a little titanium device that's implanted into the eye to release prostaglandin. In this case, it's travoprost that it's releasing. And so this isn't something that's just injected into the eye. It's done in the operating room to actually be implanted into the eye, and it can stay there and release this medication theoretically for years. And so with the iDose, there's also decreased concern about drop adherence and side effects. There's less of a treatment burden. It can be done at the same time as cataract surgery, and it potentially could last several years. I think the downside is that it does need to be done in the operating room, and it's replacing one eye drop, not necessarily multiple eye drops, and it can also be expensive. And so we know that it can be hard for patients to remember to take all their eye drops. There are some studies that show almost half of glaucoma patients take fewer than 75% of their prescribed doses, and there's so many reasons for that. One is forgetting, but it also can be really difficult to squeeze the bottle. The side effects can be hard, the cost, and then there's the component of not feeling the disease. So I just want to remind everyone that the purpose of the eye drops is to lower the eye pressure to prevent the glaucoma from further progressing. It's not actually going to get any vision back. And so, if you're using the eye drops and you don't feel like your vision's getting better, that's actually to be expected. The goal is to keep the vision from being lost anymore. Some of my other tips, if you're using eye drops, I recommend using them at the same time every day if possible, and it can be helpful to link it to a daily habit. So brushing your teeth at night if you're using a prostaglandin, or if you're taking other medication in the morning, closing your eyes gently after putting in the drop, or doing the punctal occlusion. And then if you are taking multiple eye drops, to wait a few minutes between the different eye drops, because theoretically one eye drop could wash out the eye drop that you just instilled. If you do have an implant, if you notice any pain or redness or vision changes, definitely let your doctor know. And I'm here if there's time for questions. And I also have my email up here. I think someone mentioned their why, and my why is really all of you and the patients, and providing the best possible care that we can. And so feel free to email me at any time, or come visit the VA while you're here. Thank you.